So after seeing radiotherapy in general, we will focus today on particle therapy, which is of course a big story in Darmstadt, where we pioneered carbon ion therapy in Europe with Gerhard Kraft. So it's obviously a big topic here. I don't need to go back to the physics. So why people want to use particle therapy? Use particle therapy because of the physics, of course. The depth dose distribution, again, this is the depth dose distribution for photons, very high energy photons, and this is 18 megavolt photons that are seldom used for therapy, but they have a much better depth dose profile than low energy X-rays that drop even more quickly. But in any case, this is not comparable to the nice Bragg peaks that you see. Protons that are by far the most used particle for charged particle therapy, or carbon ions. And you see, of course, you can have the same energy of protons and carbon ions, but the struggling, if you remember the physics lecture, the struggling will be higher, of course, for protons than for carbon ions. And changing the energy, you can change the depth. This is important, we will see, because we always show this single Bragg peak like here, but we will see that we have to deal with spread out Bragg peak. It's not only the physics though that matter, it also matters from the radiobiological point of view. It also matters that in the plateau region, this is essentially low LET, but in the peak region, we go into the region of high LET. Of course, it depends on the particle. For protons, still, even in the peak region, we are in the low LET range. But if you go to heavier ions, you go to high LET, and then the radiobiology will be more the radiobiology of high LET particles. Now, what is the main consequences of the Bragg peak from the medical physics point of view? Well, the main consequence is that now you can spare normal tissue, because being automatically conformal, if you want, you have low dose in the entrance, high dose on the peak, so it's automatically conformal. So you can drastically reduce the number of beams that you use, and having situation like the simplest case, if you want, is the prostate. You see where in the prostate you have two opposite beams. These are protons in this specific case. You see it's very conformal, but if you do it with IMRT, you have to use many beams. You remember the lecture we did last time. This plot here is the difference, is the color difference between this plot and this plot. So this gives you the extra dose that the patient will receive if you use IMRT instead of protons. This extra dose is unnecessary. It's a dose bath that in principle the patient should not receive. And these are again another advantage, you know, in protons is that protons stop while X-ray don't stop. So unavoidably, you see also for this ocular tumor, you will have a tail of dose here in IMRT, but protons stop. Also here you see that's the difference between photons and protons. Protons stop, so they don't have this tail behind the target. And that's, you see, many different comparisons for all different types of tumors, you know, CNS, head and neck, lung, abdominal tumors, and pelvic tumors. Everywhere is a comparison of IMRT on the left or rapid arc, like here, and the protons on the right. In every case, you see the very large sparing of the normal tissue when you use particles. That's again a prostate case. You see again a comparison. Now this is a treatment with 4 fields of protons, but still you see the difference between proton treatment and VMAT. This is a VMAT treatment. So and again, this is actually heavy ions. Here is carbon ions. These are two tumors here treated with SBRT. You see that when you have 2 tumors, really you have to, the field becomes really enormous. While you see that this is how you can treat it with heavy ions. this is a case where clearly there is a very large advantage in using heavy ions compared to SBRT. Well, if you look at this case, if you look carefully, the advantage is less pronounced. This is a central tumor. These are two peripheral lung tumors, okay, in the top of the lungs. If you take a central tumor that has a lot of movement, then in that case, you see, this would be the treatment plan for SBRT, and this would be the treatment plan with heavy ions. You see that even though, of course, you have less low dose region when you use ions, the high dose region is quite significantly higher when you use heavy ions than SBRT. So you have to be careful. Depends on the tumor, what is the best combination. And that's another case, an old one, you see, showing, I showed you already this case. This is a complex tumor of the base of the skull, a chondrosarcoma, treated with IMRT, 9 fields. You can do the same treatment plan with carbon ions, only 2 fields. You see how much you reduce the dose to the normal tissue. And that's the difference between carbon ions and protons. This is the same tumor, but the difference here is the penumbra. You see, with protons, you have a much broader penumbra, with the result that the treatment planning with carbon ions will be always more sharp than the treatment plan with protons. Of course, you will have the tail here. It's a physical tail due to the fragments, so the high energy fragments. These are light fragments of the projectile that having the same velocity, but they are lighter, they have a longer range. So they will deposit the dose behind the target. This, you don't have these kind of problems with protons. And that's, you see, in the physics, is a physical measurements of the penumbra for protons and carbon ions. So one of the main issue, this is a calculation for the lung, is that, you see, when you want to keep this is the curve for the TCP, but the MTCP for X-rays and protons will be changed. You know, this is the NTCP for X-rays and this is the NTCP for protons. This does not mean, and we have to be careful about that you will see a clinical advantage. You see, if you use a dose like this one, 50 gray, your TCP will be around 80%. And the difference between the red and the green curve is so small that it can be very difficult to see any impact when you do the clinical trial. These are other examples. For example, it is generally said, you know, that for parallel organs, you can have a lot of sparing, you know, using the carbon ions. This is an example for hepatocellular carcinoma treated with carbon ions. Here you see approximately 50%, you see the red is the liver. Approximately 50% of the liver, if you look at the dose volume histogram for the liver here, 50% of the liver received 0 dose, no dose. You know, so this is really a big advantage for parallel organs using heavy ions. And in fact, you see, if you make a review of all the clinical data on toxicity using 3D conformal radiotherapy, SBRT and charged particle therapy, mostly protons, but also heavy ions in hepatocellular carcinoma, you see that this is the rate for the rate for 3D CRT, and this is SBRT, and this is charged particles, acute toxicity and late toxicity. There's always a tendency to have less toxicity with particles. And this is now, however, gives you the example of what you can do with ions. So see, this is a fractions and total dose. With protons, you really go into high doses, high total doses, but you have still a tendency to do a lot of fractions. So with carbon ions and SBRT, you can hypofractionate, which is what you want, essentially. So when we talk about application for therapy, the problem is the lateral and longitudinal extension. So you have a tumor which is 3D, and you have a Bragg peak, which is essentially a peak. It's like a needle. So how do you spread this Bragg peak? You have two possibilities. One is the passive beam shaping, and the second is the active scanning. So this is what we want. We want to superimpose different Bragg peaks along the depth of the ion. The superimposition must be done with different intensities in a way that at the end you get a flat spread out Bragg peak. The flatness of the spread out Bragg peak can be in physical dose or in biological dose, depending if you want to take into account that the LET is different and then the biological effectiveness is different. So again, you see here what happens when you make a spread out Bragg peak out of your particles. And that's essentially what is the difference, if you want, between using photons, you see the crossfire of photons, and the crossfire of protons, you see, in a target like this. So you have, let's say, if you crossfire 2 X-ray, you get this kind of depth dose distribution. If you crossfire 2 protons beam, you get this type of depth dose distribution. Now, for the shaping with passive device, what is the idea? The idea is that you scatter your beam and you use a range modulator and a range shifter. The range modulator, you see, something with the different thickness, so that some particles will go through very large thickness, and then let's say in this plot, those with very large thickness will be down here. Others will go through very small thickness so that they'll reach the end of the range, this one. Then you have another range shifter that changes the total range. You still need a collimator and a compensator, just like in 3D CRT, if you want, to reach the tumor at the end. There are several problems in this, as you can imagine. They have to be manufactured for each patient. There is a fixed extension of the extended Bragg peak, and there is a missing proximal conformation. So at the end, the depth dose distribution always will have these horns here. You see, because even if you have a collimator and a compensator, here you will have the problem, let's say, of the horn. Here you go in depth, but at the end you will have these horns in front of the patient. These are the examples of how to do the collimators and the compensator. You know, it's a lot of work that you do and must be not only patient specific, but even field specific. But the alternative that is now becoming by far the standard in particle therapy instead is to use active scanning and raster scanning in particular. So you have a pencil beam and you move this pencil beam laterally with magnetic field, and you changing the energy, you move the beam in the longitudinal direction. That's how it looks like. You see, in this movie, you see that you cut your tumor ideally in slices, in mathematical slices, and then you scan with the pencil beam through the slices to uniformly cover the tumor, and the movement in the longitudinal direction is given by energy change in the accelerator. That's what was done with carbon ions for the first time at GSI. It was done with protons, was previously introduced in Berkeley and then realized at PSI in Switzerland. But with carbon ions, it was done for the first time at GSI. This is the cave-M that you can still see. This is a PET camera that we will discuss later, why there is a PET camera here. And the X-ray machine, similar to conventional radiotherapy, where you take an X-ray image of the patient, the fixation mask, the patient couch, and the exit window of the beam, which is here. So one problem that we have in particle therapy, in proton therapy in particular, is that we saw that protons stop. And this is nice. You see, this is an example of a pleural mesothelioma, a bad lung tumor due to asbestos generally. If you irradiate it with protons, you can actually stop the beam so that the contralateral lung receive essentially 0 dose, and all the dose goes into the ipsilateral lung. But the problem is that we don't know exactly where they stop. Whoa. And then you have this risk, you know, particle therapy is all matter of precision. If you make a mistake, you can have this kind of disasters, which is what you want to, you should try to avoid in particle therapy. Essentially, the problem is more serious in particle therapy than in conventional therapy because of the Bragg peak. You see, a small shift in the positioning of the patient, for example, is not a big problem for photons, but is a very big problem when you have heavy ions, because now you are shifting the Bragg peak. You see another example here, then you see, assuming that now there is an air gap, and you see what is the impact for the X-ray depth dose curve, and what is instead the impact for a spread out Bragg peak. So there are many reasons why we have uncertainties. Certainly, one is the daily setup variations, the fixation of the patient, internal motion, the organ motion, anatomical, physiological changes, for example, the shrinking of the tumor on one side, or whether the bowel is full or is empty. And also the dose calculation errors in the treatment planning system, in the TPS. This can be due to inhomogeneities and metallic implants that are not considered in the treatment planning, but CT artifacts. One main reason is the conversion of Hounsfield units in ion range. So in X-ray radiotherapy, you use the CT scan to do the plan. And the CT scan gives you the absorbance of the X-rays in a quantity which is called Hounsfield units. We will see this in the CT lecture. Now, in this specific case, when you do conversion of Hounsfield units in ion range, you have a lot of uncertainties, because now you have to convert a quantity for X-rays into a water equivalent path length for ions, and this is where you get a lot of uncertainties. So as a result of this uncertainty, you add the margin, but the margins, be careful. You can say, okay, how big is a margin? It's not so big, you know. But actually, a nice example that was done a few years ago by in a Belgian paper, it shows that imagine that the margin, let's say, is like let's say, if you want the passage from GTV, CTV, and PTV. No, you can enlarge your PTV and say, okay, I add 1 centimeter more. 1 centimeter is small in comparison to a tumor which is 10 centimeter. Yes, it's small, but if you take the volume, when you put the margin, you put the margin in 4 pi. And if you take the volume, it's like the orange skin. If you take the orange skin and you take all out and you look at the volume of the orange skin, well, that's not far from the volume of the tumor itself. So you are actually irradiating a very large volume. You see, a 6.5 millimeter thick margin consists of the same volume as a 5 centimeter diameter target, an orange. So it's a big problem. It's a big problem. and you have to take them into account. The numbers are not small. You see, there are the margins that you have to introduce. You see, considering the energy spread, the uncertainty on the end of the range, the anatomy, the Hounsfield units uncertainty are of the order of 3.5% of the range, plus 1 millimeter, which means that, you know, that for a 15 centimeter, you have something like 6.3 millimeter. And the total, if you take everything, if you also take into account the range straggling, then you come out with something which is comparable to 1 centimeter compared to an ideal distal penumbra of 1.7 millimeter. You lose so much. You lose really a lot, you know, 1 centimeter, both in longitudinal and in transverse, you see, because you also have the same problem in the transversal direction. So you come out with a situation like that, you see, where a nice treatment planning like this, where essentially you spare the spinal cord completely, and you have the esophagus, you see here in the blue-green region, becomes bad like this, where the spinal cord is now in the field and the esophagus is now in the red area, you know. So it's a big problem. It's a big problem. But how can you reduce? You see, this is an example of how it is now calculated these days. Range uncertainty. What are the factors that contribute, and how big can be the final number that comes out? How can we reduce these uncertainties? Many different ways. Essentially, 3 ways are under study. One is, in fact, PET. So the use of PET for visualizing the beam. One is prompt gamma. So you use the nuclear reactions that produce prompt gamma to see the end of the range. Of course, there should be no more prompt gamma when the particle stops. And the other one is to use proton radiography or tomography instead of CT. So you jump the step of Hounsfield units to water equivalent path length conversion using directly protons to make the CT. These are other examples of how can you handle the moving targets using 4D CT, so the treatment, a superimposition of many 3D CT that gives you a 4D CT. And then you need motion detection, motion tracking, and of course you still need treatment verification. Now, why PET? PET, we will see more about PET in our imaging lectures, but to be short, PET in carbon ion therapy, you exploit the projectile target like carbon-11 or also carbon-10 that are beta plus emitters. And so the beta plus annihilates with an electron, and there is an emission of gamma rays, 2 gamma rays at 511 keV. From the coincidence of this emission, you reconstruct the point, and so you can make an image. The dose verification with PET, though, is a bit complicated because you see, if this is the treatment plan, this is the measured activity to the right, and this is the predicted activity. You have the problem of the washout, so that the radionuclides move, and you have the problem, the physical problem, that the peaks are not in the same position. But still, you see, you can do nice things. This is a nice movie showing the data in the simulation for the PET imaging of a tumor at CNAO. You see, these are the data, and this is the simulation, and you see how well you can actually reproduce the position of the beam. And this is another example. You see again. With the data and the simulation, you see total beam, and let's say the position of the Bragg peak that should correspond to the red curve here, the distal part of the Bragg peak. Okay, target motion. Of course, target motion is a big problem. We saw this already. Essentially, you see, the main problem is the lung, because that's where you have the biggest motion. And you see that if this is a static treatment plan here, this is a non-compensated treatment plan. This is called interplay. So the interplay is the result of the movement of the beam and the movement of the target. So you have two movements, and then your treatment plan will be degenerated, like shown here. And but you can compensate using tracking. I mean, if you can track your tumor, but this is not still done in the clinics. This is you see how you can do. This is a interplay, the treatment plan with interplay, and this is a treatment plan with tracking, where actually you take into account the movement, so you can get a good coverage of the target. Again, examples here of the 4D optimization. So now you can do your treatment plan not on a 3D, not on a single CT scan, but in 4D, so that you take into account the movement and you optimize your treatment, including the movement. So this means that we have more and more centers doing particle therapy. This is a world map of the centers of a few years ago, though now the situation is quickly changing. You see, this is 2013. This is the number of patients. But if you look at the PTCOG webpage, you will find the data updated to 2019, and they are fairly different already, increasing very quickly, because you see, this is the situation in 2017, where there were 72 centers, but you see how quickly they are increasing. So we should check. Now we are already probably in the order of 100 centers active in 2020 all over the world. Now let's go a little bit on the clinical results from particle therapy. What are the clinical indications? That's always very controversial. Generally speaking, let's say typical, because of the problem of the moving target, the typical clinical indications are tumors like in the skull base, the spine tumors, the eye tumors, tumors that don't move. Moreover, there is a lot of solid results, let's say, in the pediatric tumors. Of course, for pediatric tumors that are very often brain tumors, the sparing of the normal tissue is extremely important, because you can, the probability of survival for pediatric patients is very high. But the irradiation of the whole brain causes severe late effects, including a decreasing IQ and, let's say, very bad quality of life. I mean, the children survive, but their brain will not work completely as well as without any radiation, let's say. So now there are more and more data on head and neck tumors, where, of course, the problem of the toxicity is particularly interesting, and some good results also for prostate, a bit controversial but good. But in principle, you know, particles could be useful for every tumor. One example, which is a bit surprising, is breast cancer. Breast is a sensitive tumor. So you would say, why I want to use protons for breast cancer, which is a sensitive tumor and apparently is not very close to organs at risk? Well, this is a case where you have approximately 200,000 new cases per year in US, only US, affects the women in the most productive part of life, you know, when they are between 40 and 60 years old. Most patients survive. There are 2 million survivors of breast cancer in US. Most are diagnosed at early stage and receive radiation. But there are horror stories from the side effects of radiation that leads many women to choose mastectomy all immediately, let's say, to skip any risk. You know, this is Angelina Jolie had a double mastectomy with implants, of course, because she had the mutation in the BRCA1 gene, which is responsible for breast cancer. So her risk of cancer was supposed to be high. Actually, one of the organs at risk in breast cancer therapy, especially for left breast cancer, is the heart. You see that normally the treatment, like you see here in the panel C, is given by two tangential fields that give this kind of treatment plan here. The heart is unavoidably in the field. And in this study, it was shown that the coronary arteries of the heart that are in the field tends to get stenosis, and then they will cause myocardial infarction. So the major heart disease is the main toxicity. But if instead of X-ray you use protons, you see, because protons stop, you can actually spare the heart. You see. So other typical indication, of course, as I said, are the chordomas and chondrosarcomas, these skull of the base tumors that were very much used in Darmstadt, were among the first tumors to be treated in Darmstadt. This is an example of a patient before irradiation and after irradiation. You see the pressure of the tumor on the eye that disappears after irradiation. Now, the quantity used here is gray equivalent. The reason is that the idea in carbon ion therapy is that you use a biophysical model to correct the physical dose in a way that gives a uniform biological dose in the target. This is because, of course, the LET changes a lot. So in one part of the Bragg peak, the LET is not the same as in another part of the spread out Bragg peak. Adenocystic carcinoma here, examples. This is, you see, the amazing results, the initial results at short time for carbon versus IMRT for adenocystic carcinoma, showing a large increase in survival for patients having carbon in addition to IMRT. This is a boost of carbon to IMRT. Skull-based chordomas, too, you see how complicated they are and close to organs at risk like the spinal cord here. And you see, what is the final result? They say this is the TCP, not necessarily survival. The patient can still die for other reasons, but the TCP as a function of the mean dose in gray equivalent again. So corrected for the biological effectiveness. You see that the main effect of the carbon ions or protons are green, blue is X-ray. You can increase the dose, exploiting the Bragg peak, and in the case of carbon ions, exploiting the RBE, you can go up with the dose, and if you go up with the dose, your TCP will increase. Again, it's the story of the BD in SBRT. You know, if you increase the BD, or in this case, specific case, you increase the total dose, at the end, you will have a better TCP. This is now shown also when you look at the long-term results. Now the results, of course, the clinical trial at GSI was stopped in 2007. So more than 10 years follow-up there. Now you can see this is the local control is about 50%, and the overall survival is also about 50% in these patients. At 10 years, you see you have a 54% local control and 75% survival. But the most of the experience on carbon ions in particular come from Japan. These are the Japanese sites. You see, they treated a little bit of everything here in Japan. And in some cases, they did it with the extreme hypofractionation, like for stage 1 non-small cell lung cancer. You see, for stage 1 non-small cell lung cancer, the Japanese went down to one single dose, single dose treatment with very high local control. Unfortunately, because of the metastasis, the survival is not as high as the local control. And also for prostate, you see there is a tendency to go to low fractionation, and you see that the results show, in comparison to the radiotherapy or radiotherapy plus hormones, show a survival of 82%, 87% at 5 years, against, you see, 63% or 52% with the radiotherapy alone. An interesting application is certainly pancreas, because pancreas, being a hypoxic, is particularly interesting for heavy ion therapy. And pancreas, as you have seen in the statistics of the cancer, is a very lethal tumor. One of the reasons it's so lethal is actually that it's so hypoxic. And the results in Japan here are very interesting. You see the results, this is the results of a combination of carbon ions and gemcitabine, which is a chemotherapy agent. If you compare now the NIRS results, give a survival at 2 years about 44%, compared to a very dismal survival at 2 years, you see with X-rays plus gemcitabine 12%, gemcitabine alone is only 4%. The centers that use, of course, there is not only HIMAC, but in Europe there is a Heidelberg, the Heidelberg Ion Therapy Center, the only center with the heavy ion gantry, which is enormous and very heavy and enormous. This is CNAO instead in Italy for carbon ions, and another European center. There are other 2 European centers. One is in Germany, again, is Marburg, that belongs to Rom Clinicum, and one is in Austria, which is now